Good afternoon, ladies and gentlemen. My name is Christopher Cannon. I am the Senior Manager here with the National Coalition for LGBT Health in Washington, D.C., and we are very excited today to present this webinar as part of our LGBT Health Awareness Week, and we're very excited that you are interested to participate with us today. So we are going to be talking today about it's time for trusting relationships. And this is, as I said, part of our LGBT Health Awareness Week. The week was created in 2003 to promote increased health awareness and outcomes in the LGBT community and the need for cultural competency in the healthcare system. The week and the theme were created this year by members who helped inform this for us, and this has been set to create the stage for our year-long coalition activities in advocacy, education, and health services research. Take a moment to discuss the theme with you. You've seen in our promotions and materials, our theme was "It's time to come together," as we are hoping to bring all parties, consumers, providers, and organizations and different disciplines together to discuss LGBT health disparities. And part of that was trust, transparency, and truth. And each of these we've been focused on over the course of the week, as it is important to build trust with our providers and within the healthcare system and ensuring that culturally competent care is provided. We are also calling for transparency within our healthcare system and making sure that we advocate and collect authentic data on sexual orientation and gender identity so that we can get a complete picture. And truth, we are encouraging all members of the LGBT community to tell their truth, to tell their truth about their identity, their sexual orientation, and their health needs to their providers and to their health system. As we advocate for ourselves, we are able to provide further education to the healthcare system and work to make it better moving forward. As part of this work, we decided to do this webinar today, and we have 4 amazing speakers who are doing great work in the country. We have Narit Sheen from Mazzoni Center speaking on transgender health. We have Dr. Louis Freddie Milano from Community Healthcare Network in New York City speaking on racial and ethnic LGBT minority health. John Stryker, a nurse practitioner from Howard Brown Health Center in Chicago, will be talking about gay and bisexual men's health, in particular with PrEP. And then we will conclude with Liz James, the Chief Executive Officer of the Lesbian Health Initiative in Houston, Texas, who will be addressing LGBTQ women's health issues. So at this point, I will turn this over to Narit.
Okay, now we can hear me.
Yes.
Thank you, Christopher. Thank you very much. I'm very honored to be in this wonderful webinar with such wonderful people and with a lot of participants. If I am correct, there are over 200 people right now listening to this. So, as Christopher said, I am the CEO of Mazzoni Center, which is a health and wellness organization in the Philadelphia region. Although I am going to speak mostly about creating a transgender practice and the steps that we did to do that, we all know and understand that transgender and gender nonconforming people face injustice everywhere. It's at home, in the schools, employment, housing, police, and so on and so forth. So we do need to think about transgender disparities in that global outlook, not just healthcare. And you will see when I talk about the comprehensive array of services that Mazzoni provides that we address those issues as well. The National Transgender Discrimination Survey has really looked at a lot of those issues. I am only going to put up the issues referring to healthcare. As you can see, there is refusal of care, even harassment and violence in a doctor's office, and lack of providers' knowledge, and in which we hear again and again trans individuals saying to us, I am tired of being the educator of my provider. I want my provider to know about my needs and my health. So no wonder that this are the issues facing transgender individuals, and it creates distrust, avoidance of medical care, and obviously results in the end in negative health outcomes. I have included here a couple of quotes that we hear every single time, and we know that these testimonials are just the tip of the iceberg, and that we hear this in our medical practice from many, many of our clients and patients. So how do we build a trans-inclusive program? When we decided to initiate services, we were faced with, yes, we are an LGBT health organization. We had the T in the LGBT, but really, when we looked at it, we found out that we did not really have any specific services for the T in our LGBT, and that we were not very competent. Now, I'm talking about a decade or so ago, because we started about 13, 14 years ago. And our challenges were that we really did not know the population size, and I have to say that is still kind of a question mark. But you will see that once we built it and they came, how many transgender patients and clients we have across our services nowadays. So even though you don't know the population size in the place where you are going to initiate, please know that you will build it, they will come. What we didn't know, what was the priorities of the population needs, and you will see how we address that issue. Even though we are an LGBT organization and most of our staff are LGBT, we didn't at that point have a lot of the T in our staff, so we couldn't kind of say that we reflect the populations that we serve. Also, our website was not very specific, and our media, at that point, I think there was no Facebook. But our website did not really reflect the T in the LGBT. So with the theme of trust, transparency, and truth, I want to go through those three, how we created the programs that we now have. So to make ourselves sensitive and addressing the needs of our community, we conducted a trans health needs assessment in 2002, and the survey was created by a committee that was comprised of consumers, our case managers, clinicians, and what we asked was, would you come to Mazzoni Center if we had the services that you needed? And what are those services? Based on, and I think we got, if my memory serves me right, about 150 responses. It's not a huge number, but it was enough to start pointing us in the right direction to create an LGBT and a T more appropriate medical care. So we also at the same time created a community advisory board, which kept in line with us as we started to put in the services. Obviously, the first thing to do is to review all agency policies and materials to make sure that they really reflect the LGBT and especially the T. And it's not just the policies and the materials, it's also the way the agency physical place looks and to reflect the populations that you serve. We very aggressively recruited transgender providers and support staff, and I am glad to say that today, out of 130 staff members, 13% are trans, and out of our clinician staff, 22% are transgender. So clearly, we have come a long way, and we reflect the population that we serve. We also, in creating the medical practice, and all of our other services, they're either free or have a sliding scale, so that nobody feels like they cannot afford or are eligible or deserve the services that we provide. And I will show you the comprehensive list of services that we now provide. In the years, once we got more competency, we've started reaching out to local medical schools, and our medical director and our other providers really would do one-on-one for all the medical schools in the region, because no one agency can ever be everything to everybody, and the idea is that there needs to be many Mazzonis, and or that providers need to be knowledgeable about trans care. In looking at transparency, we have been working with the state and the local on something that is both national and statewide, and that is data inclusion. I am part of the State Health Equity Advisory Committee, and one of the things that I keep pushing is for LGBT data inclusion. Obviously, as part of the coalition, we support the coalition's work, and I think research is another issue that is on the forefront, because there is very little research around trans individuals. We currently are collaborating with Drexel on a long-term effect of hormones on cardiovascular disease risk. So this is a retrospective kind of chart extraction, and we have over 10 years of charts of our transgender individuals, so there is a lot to be learned from that. With insurance companies, this is an ongoing thing, of course. On a regular basis, people get rejected for whatever services they need, and it's on us, on the case managers, and on the providers to be in touch with the insurance companies. And especially now that the landscape is changing with the Affordable Care Act, we need to be much more proactive. We are actually currently also working through our legal department in Pennsylvania, in the state, to remove the exclusion regulations for Medicaid for surgery-related services to transgender individuals, the same way that Medicare has removed it. So that's kind of in the making. And when we talk about we need to be true and we need to tell our stories to our providers, I think we also, as an agency, need to make that much more easy for our clients. So, for example, when we are collecting demographics, we ask for gender, we list male, female, transgender, male to female, transgender, female to male. We put other as well. When we talk about sexual orientation, we talk about heterosexual, straight, heterosexual, gay, homosexual, gay, lesbian, bisexual, unsure, does not identify. We ask people how do they self-identify. We ask for what is your legal name, preferred name, name change status, what pronouns do you want us to use, what is your gender identity, what was your natal sex. So all of these questions really help people and are open-ended in asking them and easing the way into being truthful with the provider. So after doing all of that for over 30 years, we now in our medical practice have over 2,000 unduplicated transgender patients in our overall practice population. In our behavioral health, about 25% of clients identify as trans nonconforming out of about 400 and some patients. In case management and the housing, we have 127 clients. And in our legal services, out of about 500 to 600 intakes, 80% are trans-related, mostly in regard to discrimination and or name change, gender markers, etc. Here is the comprehensive current services that we provide. Clearly, medical primary care, HIV care, hormone therapy. About a year and a half ago, we started seeing more and more young people, and we created the Pediatric and Adolescent Comprehensive Trans Services, and which it's a team consisting of medical providers, social workers, nurses, and legal as appropriate. Clearly, we're working with the family, because if we're talking about 5-year-olds, we're not talking about any medical procedures or any hormones, but we're working with these young people and their families, and sometimes with the legal department, with the schools, and so on. And as these children reach adolescence, if needs to be, we advise on blockers and so on and so forth. We do have 2 drop-in clinics, one for adolescents. Actually, with the PTAX program, since we started it, we now have about 70 kids participate in that program. Drop-in clinics, we have an adolescent every week drop-in clinic, which we see about 400 young people every year, and unduplicated, and clearly it's a drop-in, come get medical care, get connected to benefits, and so on and so forth. We also have the True Clinic, which is a late night, twice a month. Specifically, it stands for Trans Resources, Unity, and Education, and it provides medical HIV testing, counseling, and connection to services. Actually, out of True came, and out of the outreach and our wellness project came out Sisterly Love, which is really leading ourselves via education. It's kind of a leadership development and organizing skills for mostly for trans women, and we now have they're doing workshops out in the community. So we really create a community that then can go out and work with the larger community. Clearly, we have support groups, We have legal services, as I said. We also have laser hair removal as part of our primary medical care, and we do a lot of social work with individuals. I think I have, and of course, the staple that many of you may know, Mazzoni Center. We are now in the 14th year this June of the Trans Health Conference. This conference started 14 years ago with about 40 participants and 9 presenters, and last year, in our 13th year, we had 3,500 people participating from all over the world, and we now have basically tracks that are community, and then we have professional tracks, meaning teaching medical professionals, behavioral health professionals, and legal professionals about the needs of trans individuals. Here are some images from that. As you can see, people are having a great time. And the community involvement in the Trans Health Conference is that all the decisions about the program itself, about the workshops, about the theme for the conference come from the community, from the working groups, from the steering committee, and so on and so forth, and the advisory board that is there. There is also religious tracks in the community and so on. What is the impact on all of these programs that I have been talking about? Clearly, there is better health outcomes for the individuals. I think there is community visibility. If you are in Philadelphia at the first weekend in June and see 3,400 people at the Philadelphia Convention Center, you know that this community is very, very visible. I think there's a lot of benefit to individuals and empowerment and community empowerment, and of course, the outcome of better provider education throughout the tracks and throughout whatever that we are doing throughout the year in medical schools and in the corporate world, where we also go and discuss LGBT and trans issues. I think I have used my 10 minutes, so I will stop here, and hopefully when we get to the Q&A, we'll have a chance to respond to your questions. Thank you very much.
Thank you, Nurit. We appreciate your presentation. At this point, I would like to first say we have hit capacity today on this webinar, so if you do have colleagues in your clinics or offices who are trying to get in, even if they did register, they may be having trouble. I just wanted to let everyone know this webinar is being recorded, and we will have the recording online within the next day, and we will have the full slide set also available for individuals. I also should have previously shared, and I forgot out of excitement, if you have questions for our presenters, you can ask them by clicking the little hand icon under the attendees list. That will signal for us when we get to question and answers that you have a question, or you may type your question in the Q&A box, and we can address them at the end as well. So at this point, I will turn the webinar over to Dr. Milano. One second. Dr. Milano?
Yes.
There you go.
Okay, thank you. Good afternoon again, everyone, and thank you, Christopher, for inviting me to do this. I think it's a very exciting week. Hopefully we'll be able to share some of the experiences that we have from our part in New York City. Community Healthcare Network is a federal qualified health center network that we have 11 centers in one mobile unit. And the background is that we started as a women's health organization. And as responding to the different community problems and challenges, we decided to establish our LGBT programs, especially because we serve people from all over the world, low-income areas, racial minorities, and we wanted to make sure that everyone gets access to care whenever they need it. We believe that in order to access care, you should be able to do it in your own community, and rather than to have to travel to a specific base LGBT provider. And so I'm just going to go through this. Just wanted to give you a little background on my agency and jump right into it. With our presentation, we have the primary care. Right now, a lot of people are talking about the continuum of care. However, when we started the program, we decided that that's the only way that we could do it. And back in the days, we were thinking about doing both prevention for negatives and prevention for positives. And this is something that really has paid off in the sense that being able to offer all the services at the same time brings the people to us, gets people engaged in the care, and CHN has integrated the health services for the LGBT in all of our centers. We don't believe that people need to go to different places to get the services. On the next slide, I'm trying difficult to remove my slides from here. One second. The goal is to improve the overall health of the LGBT community. We want to provide appropriate care to everyone in the context of the service, and we want to emphasize the integration part. This will be of great help when decreasing the barriers to access to health care if we talk about integration. It will increase knowledge about the health system, will empower our patients to ask better questions, and it will help to make informed decisions and move away from the one-way concept when the doctor makes the decision, but rather we establish a partnership between patients and providers. The more you are able to provide in one setting, the better retention you will have. And by doing that, we also are able to get a partnership with the clients. We know that sometimes this is a difficult deal to make, but it is doable, and it's our commitment, part of our commitment that we made. In structural barriers, we find that coming as an immigrant from other countries and being able to get access to medical care is a very difficult thing. We have done our we did a research in the city and trying to see what was the most impacting for our patients. Insurance is a real barrier, and it causes them not to have access to care, because once that you go to a front desk and people are going to ask about your insurance or what are you here for, it kind of revives all the different barriers that we have. You know that in many ethnic cultures, going to the doctor means being associated with disease. Many people of color, especially men, do not go to a doctor because they are supposed to be the stronger gender. The LGBT still carry the stigma of AIDS and STI transmission. We know historically that many times the medical society has put the LGBT issues in the back burner. And on top of that, we know that it is very difficult to establish the criteria for which you're going to access insurance or medical care. Going to the front desk, and I will mention this several times, it really can turn a patient away. Also, prioritizing other patients' needs, housing, food, transportation, it is part of the care. We don't just concentrate on the medical, but we need to focus also in the other areas. Clinical competency and barriers. We try to make emphasis more than the cultural competency because we understand that the clinical competency has to include cultural competency. If I'm coming from a country when my religious background is not a friendly one to my LGBT orientation, I'm going to keep that in the back of my mind when I access medical care. We had the problems with the clinicians that in many instances when we work at the clinic, if it is not an LGBT-centric facility, the staff might not be respecting the complex cultural backgrounds that we might bring with us. Also, there is assumptions about one's sexuality and gender identity. We try to believe that because a person is defining himself or herself as a lesbian or a gay man or a trans person or trans experience, we encapsulate them right away in boxes without really thinking about that we are talking to a whole human being. And this is totally wrong. We are very judgmental. This also goes across in many instances the medical community, the providers. We assume that when a person has more than one partner, that this person has been, and I hate that word, promiscuous, because it's just having more partners than I have, rather than to think about sequential partnering, and that in many instances, they have been forced to a type of life that is beyond one's comprehension. The personal curiosity versus the need to know is something that I had observed in the medical community, because we try to go over, and I see mostly in the people of trans experience in our clinic, when do we ask about pre and post? When we have a gay man, we make the assumption that that person is a baron. When we have a lesbian woman, we make other assumptions that are wrong. And that is ongoing teaching process with the providers that we need to continue and we need to maintain and really see what is that we can offer some technical assistance. When we are addressing the LGBT and the ethnic minority identities that we found in every area, we still need to be conscious of the stigma that medical care means. Mental health is in many cultures still associated with a mental deficiency, with craziness, and that brings confidentiality issues to many of our patients. How are we addressing that stigma and those confidentiality issues? We also know about the mistrust and the language barriers. I know that it's very common for many of us to have language lines, but being or coming from countries when being gay, lesbian, or people of trans experience is an unlawful behavior, we have to be mindful of that. We have to remember that when we put our patient to talk online with somebody else that whose face is not showing, a mistrust may develop, and we need to reassure and affirm the client, the patient, that that's is his or her best interest. Some of the barriers that to access care, we focus from the moment that the patient enters the clinic until the moment that the person leaves. The intake and registration, the front line need to be more better trained on a welcoming environment for the client. LGBT members of the minorities are looking for a safe space We want to make sure that when we go to the clinic, we're not going to be judged. We're going to find good clinical competency, and that somehow the people behind that desk will represent who we are. So I think that it's very important to look for the gatekeepers in the community to see who is out there, who is going to help us, and who's going to navigate us to get the trust from the community. Nothing wrong by asking and looking in the community for partners. The gatekeepers are always the one who knows who's coming, who's leaving, and where are we going. This slide is just a reminder for myself and for everyone that I want to share with everyone that one thing that we keep in mind when we are working with the LGBT, especially from the minorities, being racial or ethnic, we have to not one model fits all. We have support groups. We have, I put it Spanish and English because that's my language, but we really have to look for people who identify with that particular culture and make sure that we can ally with some of these people so we can partner with them and on keeping the clients, on keeping the patients coming to our clinics. And in the following is that the fact that not one single model applies to all. We have individual interventions that may work for one person. We have also group interventions. We have dairy, so other type of interventions. And when this happens, we need to be creative. Sometimes what we have found that is more efficient is when we involve the patients and we ask for their input or interventions such as PEP and PrEP, which is our next big thing with the LGBT community in New York. And unfortunately, sometimes we don't concentrate in these populations. Sometimes the health disparities try to get bigger and bigger and deeper between the Caucasian community versus the minorities, and PEP and PrEP is a good example of it. So this slide is basically telling us that not one model fits all, and that we have to be cognizant of the time that we spend with the client and how are we going to the services that we intend to provide for them. Again, it's one thing that the more integrated we have the services, the better retention we have in there. And we have an association of HIV with the LGBT community from the very beginning of the AIDS epidemic. And unfortunately, it's going to happen. But as somebody said yesterday, the LGBT was the first response to the HIV crisis, and the LGBT is very likely that also can help in finding a cure. So another thing that are very important to develop along with the medical program, partner up with other organizations in your community that do some skill development, job readiness. We know that many of the immigrants and other, because of the bullying, people do not finish high school. They don't go to college, so it's very difficult to get realistic employment. So we try to work with our patients and setting goals and looking about the safety, dealing with the bullying and the stigma. Sexual health is something that is very important, and we need to talk by its name. We have to talk to the patients about anal health, sex work, because we have patients who do not identify openly as gay or lesbian or bisexual, but they are working in the sex business, like somebody mentioned to me last week, in the sex services provider. So sexual health is very important because it's going to keep them engaged, and it will also give us the opportunity to maintain them in care. Again, partnering with other organizations in the community is also something that CHN does not provide yet, but we have partnered up with other organizations in the community throughout the city. And finally, the case study is a very simple way to tell everyone Again, how do we need to include other members of the community in the things that we do? And by being client-centric, patient-centric, we'll be able to offer the medical, behavioral, legal referrals, social services, nutrition, or other services. I just put nutrition, but it could be anything. Health literacy is very important because the health literacy is something that we want the patients to understand, better understand their care, their needs, and how to advocate for themselves. And especially for the members of the LGBT community, it is very difficult. Sometimes we are already traumatized by previous experiences, and we want to make sure that that doesn't happen to the new arrivals, new immigrants, new undocumented, new members that are of the generation that is growing up. Thank you.
Thank you, Dr. Milano, for a wonderful presentation. We are going to be moving on now to John Stryker from Howard Brown. John, we will make you presenter momentarily.
Good afternoon. Thank you, Christopher, for inviting me to participate in this webinar. And I also want to give a shout out to the Mazzoni Philadelphia Trans Health Conference, which I attended myself 3 years ago and had an amazing experience. So if any of you are healthcare providers and have the opportunity, strongly recommend you go if you have the chance. I'm going to be presenting on PrEP, or pre-exposure prophylaxis in an LGBT health center. And I'm going to review kind of the indications, what it's like to prescribe PrEP, and then what we learned in setting up our clinic, and hopefully things that we can impart to people who want to go forward from here and prescribe PrEP. So the indications for PrEP are men who have sex with men who have multiple partners, or who are in serodiscordant relationships with somebody else who's HIV positive, or men who have sex with women and women who have sex with men who are in serodiscordant relationships, or who are going through conception and working on having, trying to achieve a pregnancy. PrEP is also indicated for IV drug users, and all of this is to prevent HIV. PrEP is very safe. In one of the bigger studies done at IPREX, renal safety, there were only 10 discontinuations due to creatinine rising in patients, and 7 of those were in the study drug arm, but 3 were actually in the placebo arm. So 9 of those patients were actually restarted successfully and continued on PrEP, and there were no hepatic issues whatsoever seen in IPREX. We do a lot of post-exposure prophylaxis at Howard Brown, and we have been able to transition most of those people onto PrEP so that they have continuing protection going on. And so this is a great, if you are a provider who provides PEP, you should consider trying to get people onto PrEP, because it can help prevent them from having to return to your clinic or to your site for another round of PEP. So prescribing PrEP is actually relatively easy. You just need to identify who your patients are that are at risk. You want to do a test, an HIV test, and document negative status. We do this 2 ways. We do a rapid test in the clinic on the patient, which we do with all of our primary care patients. We try and test everybody at least once a year, or more often if they're at higher risk. And we use a standard antibody test for that. For all of our PEP and PrEP patients, we also do a 4th generation HIV test, which looks for antibodies and the P24 antigen. So it has a much shorter window period, somewhere between 11 and 20 days. And we do that at every visit. You want to assess for signs and symptoms of acute HIV. These include mostly flu-type symptoms, so things like fever, chills, night sweats, sore throat, usually pretty profound fatigue. There can be a rash on the chest and back. You want to assess for normal renal function, make sure the creatinine is in the right area, and then also that their GFR is appropriate. PrEP and Truvada is contraindicated in people with a GFR of less than 60. And then you also want to check hepatitis B status. And the reason for this is actually that Truvada and tenofovir are both used in the treatment of hepatitis B. So if you have somebody who's got active disease, you have to be careful if they start PrEP and then go off of it, they can have a rebound of their symptoms with Hep B, which could include abdominal pain, nausea, vomiting, jaundice, things like that. PrEP is just tenofovir and emtricitabine, FTC and TDF, in a single pill called Truvada. It's 1 tab given daily. You never want to prescribe it for more than 30 to 90 days, depending on how you decide to do things, because you want to be able to use refills as a way of getting patients back. Most patients come back regularly when they understand why, but we do have a few that we have to keep a close eye on, and the only way we can get them back in is if we threaten not to refill their medication. The CDC recommends the first checkup at 3 months. We actually do a 1-month check, and where we check creatinine and assess for side effects, but this can also be done at 3 months. And then we also check for bacterial STIs, so chlamydia, gonorrhea, syphilis. This is actually going to be a lesson learned that I'll discuss later, but we do swabs for oral and rectal gonorrhea and chlamydia in all of our patients. We assess for med adherence. I do it the same way I do it with my HIV positive patients, which is, have you missed any doses? If they've missed more than 1 or 2 in a month, I talk to them about that, find out what happened, what's going on, try and troubleshoot with them to prevent that from happening in the future, and then reinforce why med adherence is so important. And then we also assess for side effects. Only about 1/3 of people who take PrEP get side effects, and it's usually only for the first week. It's primarily gastrointestinal, things like some mild nausea, and that usually goes away if people switch from either taking it in the morning or taking it in the evening or taking it with food. We go through some behavioral risk reduction support, so I discuss with patients who they're having sex with. I'm going to talk about doing a good sex history later, but it really comes down to you got to talk to patients about their anal sex practices. If they top, if they bottom, do they use condoms with everybody, with nobody, or with certain people? How do they assess that risk? And then I do a lot of education therein around how they should be protecting themselves, and reminding them also that PrEP doesn't prevent bacterial STIs. If you have women who have sex with men who are taking PrEP, you need to do a pregnancy test every 3 months. And if you have IV drug users, you should offer them access to CleanWorks and referrals to treatment services every time you see them. So PrEP at Howard Brown, we had originally started doing PrEP within our primary care practice, and it became obvious pretty quickly that between all of our PrEP patients and then also our PEP patients that we were getting overwhelmed. And so we created a dedicated clinic, which is currently at 15 hours a week. It's going to expand soon to 20 hours a week, and it will probably end up even more than that as time goes on. Some of the lessons learned, the swabs for oral and rectal chlamydia and gonorrhea. We looked at 1 month's worth of data, and in our men under 24, we realized we would have missed just over 50% of our chlamydia and gonorrhea infections if we had not been doing swabs. That urine testing alone doesn't detect oral and rectal gonorrhea and chlamydia, and a lot of people are asymptomatic. So we swab everybody now, and we're working on a protocol to teach people how to self-swab if they don't want to have a provider swab them. The other lesson that we learned was that insurance and the paperwork associated with the patient assistance programs is kind of overwhelming. And we have been motivated to try and get people on to PrEP as fast as possible, especially if they're higher risk. And so we've done whatever we can to help move them through the process. But many patients with insurance have high deductibles and have no anticipation of what that means or how they're going to pay for medication until they come along and just suddenly discover that they have to pay the first $3,000 themselves. The other thing is the patient assistance paperwork usually requires things like tax forms or a couple of check stubs. All of that, we now have a person who is working nearly full time to get our patients registered for all this. So if you were a single provider or in a small clinic, you would probably want to create a system where you could tell patients how to do this themselves so that they could then go forward and acquire these resources themselves. The other thing is that doing PEP and PrEP both require really good sexual history taking skills. And so I've got a reference here, an article by Nussbaum, which is a really good description on how to do a good sexual history. Talks about not assuming anybody's, who they're having sex with or what kind of sex that they're having. Sexual histories can be kind of difficult in the beginning, but the more you do them, the easier they get. And if you develop a kind of a flow to it, you can get to the point where you can ask just about anybody any question, and if you frame it the right way, they should react positively. I haven't had anybody act negatively to me yet. So advice for independent and rural providers. If you are living in an area where there's no PrEP available, you're going to have to find a champion who's willing to prescribe it. If you're a provider, this might be you. If not, you're going to have to find somebody who you can convince to do this. And as an example, just in Chicago alone, we have a number of men who are coming to us who see they go to practices that are LGBT private insurance practices, and their primary care providers there won't prescribe PrEP, and they refer them to us. So, and we're not even sure exactly why that's occurring. We get people from all over the state, people who are driving up from Southern Illinois just to get access to PrEP. So having somebody in your local area, as Noreen said in the beginning, if you build it, they will come and they will access your services. So PrEP is becoming incredibly powerful. In your practice, you can create a guide or a chart or an algorithm, and I would be happy to help you do that, to help make sure you make sure that you are doing the right testing at the right time to keep people safe and to make sure that you're doing adequate testing for STDs. I'm available. My email is there if you have any questions or if you need any support. And UCSF has also created a PrEP line for clinicians. And the phone number and the time is there, and you can call them and they can give you advice. Or I can, our clinic, and we can help guide you if you're helping set things up. I've already actually received an email from somebody who saw the flyer for this webinar, who has already contacted me for assistance in helping set up a PrEP clinic. So, and just one more thing that I would like to put in is that I was at CROI about a month ago, and one of the presenters got up and said that this is like 1994 again. And for most young people, that probably won't make a lot of sense. But 1994 was when triple therapy for HIV came out, and everything changed. And suddenly, people weren't, stopped dying, and it was seen as a revolutionary moment in the treatment of HIV. This PrEP is being viewed also, again, as a revolutionary moment. We have the opportunity here to stop infections. PrEP works incredibly well in reducing risk, and between this and using treatment of people with HIV as prevention, we could prevent any more infections from occurring if we have the will. So thank you very much for listening, and please contact me if you have any questions. And I think my last slide is just my references. Yep, I'm all done.
Great. John, real quick, we did get one question for you. How many PrEP clients are you serving?
We have over 200 currently one of the problems we're having is we're having a hard time with our EMR in tracking non-duplicated patients, but we believe we have over 200 at this point.
Great. At this point, we are going to move on to women's health, and Liz James from the Lesbian Health Initiative will begin. Thank you.
Great. And Christopher, just checking in, we have a stop in about 5 minutes, right?
Go ahead and go for 15 minutes, or your 10 to 12 minutes. For those who need to leave the webinar, they'll have to leave, but I want to continue to make sure we record this and get all the information in for online archiving purposes.
Well, great. Well, I'll head out and get started right away, and I want to say that I'm very grateful to be joining an esteemed group of folks, including yourself, Christopher, to talk about really important needs and programs and solutions that can be leveraged for us to do this work. And the story I'm going to share is really very much about the work that my organization does in terms of really the theme this year. We actually are an organization that works together, and we inspire truth and we build trust and transparency to really serve the community that we're tasked to serve. And in our case, and I'm in Texas, in Houston, we serve we say LGBT women and transgender men. Many women that are older we find define themselves as gay, so we use that as a teaching point. And I'm going to tell the story about how we do this through who we are, how we know we're needed, what we do to address those needs, and hopefully at the end of this, you'll be able to have some tools where you too can do similar work. So I think it's really important to look at, one of the most fundamental pieces of what we do and what we all must do, and I think we've heard this thematically through everyone's presentation, is, we have got to be the community creating the change that we want. And the only way that we have done that is to be the community we are trying to reach. And we actually have trademarked that. So we say we are the community, and we also believe that equality, doing that, will deliver an incredibly powerful prescription for health. So very quickly, our mission is that we are dedicated to eliminating the barriers to health care and promoting health and wellness for LGBT-identified women and transgender men, and we have 3 programmatic areas, and we believe we can't actually address that unless we do that together, not only as a community, but as a community with healthcare providers, healthcare researchers, and quite frankly, the community at large. And I'm going to zip through some of these slides because they're going to be up on the web, but we are a 501c3. We've been around since 1992, and I will note that, and I would be thrilled to know there were any organizations doing what we're doing, but I don't believe there's another freestanding organization in the country doing exactly the type of work that we're doing for the population, which is very much a story about being invisible and not having the associated funding streams to support those issues that an invisible community has. So we address these areas of effort in terms of reducing barriers through 3 programmatic areas: education, access, and advocacy. And this particular slide that I'm going to share really helps everybody understand this work. It's a pretty basic slide. We use it with the community, we use it with all of our partners, but it tells the story about our organization, what our job is, and that is we need to understand what's going on. So as I share this, I typically say we step back and we look, and what are we doing? So what you see here is, what are we trying to create transparency to? Where are we trying to build trust? So on one side, you see via 6 figures, our community, and LGBT is not one word. We all know, I think, on this call, this is an enormous population, multidimensional, multi-ethnic, and we're individuals, we're partners, we're families. It's important to know that there's all kinds of reasons why we cannot see over the proverbial wall to those that are tasked and really want to take care of us from a health perspective. And then we've got a tremendous amount of reasons why those folks, that great list of providers, can't see us. So we've found that with our community, with our providers, this is a powerful tool to help people understand what they don't necessarily have the data to see. Now, let's talk a little bit more about that. One of the takeaways for everyone is, do you know who you're trying to serve? I'm in Texas, and we have the fine distinction of being the most uninsured by percentage state in the country. We have a large population. I believe we have the 2nd largest population of LGBT people in the country, and in Houston, if you just zoom in on the greater Houston area, we're a big population, we're way outside of insurance, and it is a huge need that we are addressing on many dimensions. So I think it's pretty graphic what this is. If you are an African-American or a Latino person, and if you are an African-American transgender person, you are that much more outside of healthcare. So we've got a big job to do, and it is important for our community and for those that partner with us to understand that. Next slide, I think everybody needs to understand what's that environment like. In Texas, we do not have the support constructs in terms of non-discrimination policies, and there has been research that shows a direct correlation to health outcomes. And so it's really important for all of us to understand why somebody might not fill out their name on a form, or why they might not answer appropriately on a survey question. We've got work to do to really help empower our community members to be the truth they need to be so they can get the care that they need. And it's important for us who are leaders to have to do the job to help our people feel comfortable doing that, to understand some of those barriers they face geographically in the country. Next slide, I've got a couple of slides that will be up, but there's some great data out there, and this is brand new. So I've got it noted, but it's a brand new report called Paying an Unfair Price, the Financial Penalty for LGBT Women in America, Center for American Progress, and MAP, the Movement Advancement Project, put it up. But for the first time I've ever seen anywhere, here's a great quantification of LGBT women in the country. And it's a wonderful tool to understand who we need to serve. The next slide, you can see, even though this is sort of a financial kind of presentation, it has very specific data about the health implications of those challenges that the people who are LGBT face in this country. So we are less active, we are reporting that we aren't as in good of health, and we certainly have a much tough time as a population as a whole affording the health care that we need. I also think it's really important, particularly for anybody that is a part of a center, will be a part of a center, that they understand that LGBT women they don't have primary care providers, and we actually have data that shows that. And this is pretty recent research as well, but that means we've got to really be aware of that and figure out how we're going to reach those folks. So when we're thinking about LGBT women, I think it's also really important if you're a provider or a clinic to understand that there are specific higher health risk factors that this population faces. So I've really created a quick view of that. I think it's pretty clear we have lack of access as a population. There is research that shows that lesbian and bisexual women are more obese than heterosexual women, and we have other risk factors around cancer, including HPV and null parity. In addition to that, the population faces the same barriers that the entire LGBT population faces around mental health and tobacco. And it is startling how low the screening rates can be for the population that we serve. I'm delighted there's been some new research that has been very impactful for us to share, the fact that lesbian and bisexual women are 4 to 10 times less likely to have a PAP. So this is really meant to show you there are really critical health issues that need to be addressed. There's also data about it, and we need to keep our eye on making sure that what we develop will provide that. Now, we've got 3 programmatic areas that we do this work through, and we're very small. We have actually 2 full-time people, and you're talking to one, and we've been able to really drive phenomenal change. And you are looking at why we have been able to do that. So this is a snapshot. We are a member of many of these organizations, and we collaborate with a number of them. We'll collaborate with all of them, but it allows us to understand what is going on, and it allows us to be a voice at the table. So this is critical that we all understand the power of what one of the thematic pieces is here, and that's about working together, and it's not just in our community. Our community, and I'm a member of it, is the LGBT community, where I refer to that. We have a broad range of education programs, and I won't go through this, but it runs from educating the people that we're tasked to serve to providers, and we do that in a broad range of ways. And I was really happy on this call to hear these 3 words, Affordable Care Act. It is a policy framework that is the largest and most unprecedented opportunity we have had in this country to get our community into care. It is a federal policy that provides non-discrimination protection on the basis of sexual orientation and gender identity. And in a place like Texas, you can bet that's a pretty important tool for us to make sure we reach and bring people into the healthcare system. And I believe all of us tasked with doing health work in this country need to be very clear and have good knowledge about what this policy is and how it's going to help us do our jobs and how it's going to help us serve the communities we're tasked to serve. I've highlighted some of those key factors. And one of the areas that we need to work on, and I've again heard this on the call, is data. You know, how are we going to be transparent, and how are you going to see us if there's no data? So I am really pleased to share that in Houston, Harris County, the 4th largest city in the country, they have a health assessment that they've got to look at data, and they provide a report, and we were able to contribute to that report this year that was just published. And we actually, for the first time since it was established in 2007, there's actually LGBT-related information in this report. And it's really framed around the Affordable Care Act, Healthy People 2020, and all of those key fundamentals that we all need to understand when we communicate and do the work for the community we are tasked to serve. I'm also very thrilled to share, if you can all see this, that this particular report has 3 really key public actions that need to be taken, and this applies not only to LGBT women but the entire population. But the recommendations are that we need to gather the data, and Marie, I think you've got a really good model for that. We need to be educating everyone, the public and our own populations, and we absolutely need to develop policy and plans and improve our ability to educate and give healthcare providers and professionals the understanding and tools they need to do this work. So this is a great way to share what we do with our, what we call our access program. So LHI is not a clinic or a center. We're a community-based organization that is an agent to go get disenfranchised LGBT women and transgender men. We need to find them, we need to educate them, we need to make them feel safe and trust, and we create an emulated experience that we hope healthcare will be for them. And it is in many of the centers that are on the phone. So what do we do? So what you see is a graphic image from Harris Health Systems, that's the Harris County Health Systems in the Houston area, enormous, enormous health system. It came out of their strategic plan book, and it really is a great view of what healthcare is. It's not going to be one provider. You're going to have a clinic, primary care. You're going to have specialty clinics like mammograms, right? And you're going to have a hospital. There's going to be emergency rooms. And so this is a forward-looking view of how important community partnerships are in bringing people into the system. And basically what LHI has done is that's what we do with what we call our health fairs, is we actually go out and produce this event. We go get the providers that deliver services. We create a procedure platform to route our clients through this event that's not only get screened today and get educated, but if you have an abnormal all the way through, how do you get to diagnostics and treatment? So it's a pretty great approach to being able to see that the work we do from a vision and a strategic plan in our community. I'm having trouble with the slide here. Here we go. So we also build our programs on evidence-based methodology. You know, this is a huge geographic area, probably the largest geographic area of any major metropolitan city. And contrary to popular belief, all the LGBT women do not hang out together. And it is very hard work to reach the community, to educate them, and even if it were just referring or pointing them somewhere to that health resource that they need. So this is really a slide that shows really the tremendous work we do from an outreach perspective. We have a very formulaic approach to bringing people in through the system and delivering care. So this is what a flyer looks like. Well, this is a poster of our health fair. So twice a year on a Saturday, we work with today an FQHC, a federally qualified health center, and they're host site, and we produce an event where we are addressing high-risk factors for LGBT women. So we have 3 mobile mammography units. We have 3 to 4 providers doing PAPs and well-person exams. We have this incredible relationship with Texas Heart Institute where we're doing a full-boat heart and vascular risk assessment, and actually there's a research project that's LGBT inclusive tied to that. And we also have a knowledge fair, if you will, and it is an incredible experience that we basically manage and produce that not only delivers great care to the people that we're serving, but actually creates collaborative opportunity between these organizations and expands capacity, literally just by producing and holding this. And we can't do it. If we're 2 people, how the heck do we do this? Well, we do it with the community. We are the community, we are the change. Here's a snapshot of some of the over 40 volunteers these events take the day of to produce. It's exciting, and the volunteers love it. Also, you know, how we image and how we message is going to be key. Marie, you mentioned how important it was to think about what your imaging already is in your materials and how you reach out. Well, LGBT, how do we image that? Well, we've used hints so that we're not creating a barrier when we put up a sign about the work that we're doing. And so that's what that's meant to demonstrate. And when we hold these health fairs, there's a couple of pictures of happy clients. We're also helping people with health literacy, insurance benefits, and ultimately this is introducing our population quite often to a permanent health care home choice. If we remember from one of the earlier slides, we are at high percentages of not having a primary care provider. So the trust piece is really important. If we do not establish this trust, if we do not create these environments, people don't say who they are, and basically people don't get the care that they need. There's a whole lot of research around this, but most of the physicians, in fact, all of them that I've met in the time that I've worked with LHI, all they want is to have a good relationship with their patients so that their patients basically follow their prescriptives. And we've got to help that be a trusting experience so that people will feel safe sharing. Clinicians and providers have things to learn, but so do our population. And just a quick couple of quotes about if we do this correctly, what does it sound like? How does somebody feel about that? Well, I had no idea there were these resources. This was a really safe and comfortable environment. I had a bad experience, and my wife has insurance, but my child and I don't. So we were really pleased that the work we do is showing real positive outcomes, and we're addressing those needs for our clients. So what do you do? Well, I am absolutely thrilled to death to share this slide. I got news yesterday about this, actually. One of the things that LHI lives by is we don't want to reinvent the wheel. We want to leverage best practices, and we do that in a whole lot of ways. And so I'm pleased that our best practices are up on the AHRQ Healthcare Innovations Exchange. And literally, it just got posted yesterday. So they've included that so you can get a much closer look at the methodologies and the work that we do. In addition to that, if I could work my technology here, I just want to recap some of the things that have really been thematic through my presentation is we need to get the facts. We need to know, and they're there, whether you use the census, whether I'm going to encourage you to look at the Williams Institute, Fenway. Obviously, I've provided some resources. Understand who the community is where you are. We need to identify, the resources and know who they are. We need to create a list of resources, and we need to share that. And we need to understand that we have the ability to help really create, we can help, all of us can help create data in the system. And there's definitely a lot of information around that. The Affordable Care Act, also the information I've shared, if you want to go out to the State of Health, you can see specifically how you might be able to do similar things. And I think it's really important to note that we need to educate our own LGBT communities that they actually do have the power to make a difference. We see that in our programs. We watch a marginalized person quite often come and volunteer or get services and feel like, hey, I'm taking care of myself, I'm influencing people in my community, and I can make a difference. So we have a job to help people understand that we can all be part of the solution. And I think really, really, really not to be, I think hopefully with two people, with a bunch of volunteers can do this work in Houston. I hope it's very, very clear about how engaging and collaborating will actually allow everyone to expand their capacity, their reach, and their impact. And I'm getting ready to go down the home stretch with my last slide, which is great. So if anybody doesn't know about this, this is an important tool. We need to feel the truth, and we need to share some of these great tools. So I'm really delighted, and actually I'm delighted to be on the steering committee for the LGBT Health Link. They've put this great work together, which is a Bill of Rights. And you can go out to this site and you can print little cards that you can put in your pocket, but everybody here, if there's a center, you can provide these resources to your clients or your community. I think it is, we've got to give people the tools to be able to know their truth and also stand the line if for some reason when they've shared their truth, somebody pushes back. So that's it for me. There's my contact information, and I thank all for to stay on the call for the rest of my presentation.
Thank you, Liz, for that wonderful presentation. Thank you, everyone who presented today. We did go over time, and I want to thank everyone who stayed on the line to participate further. But due to the schedule, I'm going to ask that if you do have questions, I will guarantee to get an answer for you. You can send your questions to me via email at christopher@healthlgbt.org. But I would this time like to close the webinar and thank you for your time and your participation and wish you all a wonderful day. Thank you so much, and we'll talk to you soon.